Today we are going to study about prolapse, pelvic organs prolapse. So normal location of uterus. Normally uterus are placed anteverted and anti-flexed. So what is anteversion? There is an angle of anteversion which is about 90 degree and angle of anti-flexion which is about 125 degree. So anteversion. What is anteversion? It is an angle between cervix and vagina. V for vagina. We have to remember like that. V for vagina. Okay. So angle of anteversion. Here we are drawing cervix, vagina, and anteriorly to the vagina there is a bladder. Anterior to the vagina is bladder. So what is anteversion? The angle between cervix and vagina is called as anteversion angle. Okay. So the axis passing through, vertical axis passing through vagina and vertical axis passing through cervix make an angle of 90 degree which is called as angle of anteversion. Okay, which is about 90 degrees. Then anti-flexion. So what is anti-flexion? Angle between uterus and cervix. Okay, so here is uterus, cervix and vagina, and anterior place bladder. Okay, like that we have to draw. So what is the difference between anti-flexion and anti-version? So anti-flexion is angle between uterus and cervix and anti-version is angle between vagina and cervix. Okay, so the common axis passing through the cervix and axis passing through the uterus make an angle of 125 degrees. That is a normal anti-flexion angle. So what is abnormal position of uterus? In prolapse condition there is abnormal position of uterus. So what is this? First is retroversion. So retroversion. So angle between cervix and vagina when comes in linear, that is in 180 degrees, it is called as retroversion. What happens here? The normal angle of 90 degree is converted into 180 degrees. The axis or the line passing through vagina and line passing through cervix makes an parallel or equal line which is 180 degrees. So this is abnormal. Second is retroflexion. So what is retroflexion? That means the uterus is more flexed behind the cervix. That is, normally there was an angle of 125 degrees which was anteriorly placed, but here the uterus has gone posteriorly and make an angle. It is called as angle of retroflexion. So normally, now we are going to study about supports of uterus. So normally the supports of uterus make it prevent the pelvic organ prolapse. It maintains the position of uterus, and it prevents the descent. Okay, so normal position is maintained by the supports of uterus. Okay, so what is the support of uterus? It is a 3-tier support. What is meant by tier? Tier is meant by layers. Okay, 3-tier system or 3-tier support. First tier is upper tier, second one is middle tier, and third one is inferior tier. Okay, upper, middle and inferior tier. So what consists of upper tier? First is endopelvic fascia or the pelvic fascia around the uterus. Second one is round ligaments of ovary. Third one is broad ligament of ovary. This makes upper tier of the support. And what is the main function? It maintains the anteverted position of the uterus. Remember, anteverted position of uterus. Second is middle tier, which is the strongest support providing tier, and it consists of pericervical ring. So what is pericervical ring? Anteriorly it is bounded by pubocervical ligament. Remember the anatomy. Anteriorly pubocervical ligament and vesicovaginal ligament. Vesico means bladder. Okay, and posteriorly there is a rectum and sacral bone. So uterosacral ligament and rectovaginal ligament posteriorly, and laterally it is bounded by cardinal ligaments, which is also called as transverse ligaments. Okay, so pericervical ring, and second one is endopelvic fascia, which is same pelvic, made up of pelvic tissue. Okay, so what consists of inferior tier? Inferior tier pelvic floor muscles. Okay, floor muscles just like levator ani muscle, and second is endopelvic fascia, third one being levator plate, and the last is urogenital diaphragm. So this is inferior tier. So inferior tier provides only indirect support, while the middle tier provides strongest support. Okay, so we are just going to draw the structure being upper tier, middle tier and inferior tier of support of uterus. So this is, we are drawing, this is cervix, okay, vagina, this is the squamous epithelium of vagina. Okay, so this is what, this is a round ligament of ovary. Okay, here we are going to draw a structure which is posteriorly to the uterus. These are two lateral bony prominence which are called as ischial tuberosity. This is anterior. Okay, this is uterosacral ligament. This is cardinal ligament or transverse ligament, which are laterally present and attached to the ischial tuberosity. This is levator ani muscle, which attached to the ischial tuberosity and lateral wall of vagina. This is pubocervical ligament. Okay, this is sacrum bone. This is ischial tuberosity. Okay, this is pubis bone, and these are round ligaments and broad ligaments of ovary which provide the upper tier support. This is uterosacral ligament, okay, which is attached sacrum and uterus. This is levator ani muscle. Okay, this is pubocervical ligament. Okay, here it is attached with cervix and pubis. Okay, this is transverse cervical or cardinal ligament, which is laterally present, bounded with ischial tuberosity. So here we can see the system of three-tier system, that is supports of uterus, upper tier, middle tier, and this is inferior tier. Okay, now you understand. Upper tier consists of round plus broad ligament, middle tier consists of pericervical ring, and the inferior tier consists of levator ani muscle or pelvic floor muscle. So in pathology, what happens in pathology? Just we can see here that the bones are remains normal in their normal position, but what happens to the uterus and cervix and vagina? They descend downward due to various anatomical or pathological features, just like trauma or gravitational pull. What happens? This whole system or whole structure get descend downwards, and the ligaments get stretched downside, and this is called as prolapse. Okay, so now there is a normally descent of uterus occurs, which is a pathological feature. Here we can see on another angle how the pericervical ring looks like. So this is pericervical ring, and this is the anterior ligament, these are posterior, these are transverse ligaments. Okay, and the attachment of particular ligament. Okay, this is cardinal ligament which is attached to the ischial tuberosity. This is pubocervical ligament, and this is uterosacral ligament. Okay, so now we are going to study how or what are the types of prolapse. Okay, pelvic prolapse types. The first one being vaginal prolapse, and the second one being uterine prolapse. So vaginal prolapse, anterior wall prolapse, anterior vaginal wall prolapse, or posterior vaginal wall prolapse. Okay, in anterior wall, if upper 2/3 of vaginal wall get prolapse, then it is called as cystocele. Okay, cystocele. If lower 1/3, lower 1/3, it is called as urethrocoele, or if total get involved, then it is called as cysto plus urethrocoele. In posterior vaginal wall prolapse, there is posteriorly present rectum, so rectocele, and vault prolapse. In vault prolapse, there is an enterocele. Okay, in uterine prolapse, uterovaginal prolapse or congenital prolapse. Okay, these are the just basic types of prolapse. Now, what are the clinical features of prolapse? First, there being feeling of something coming down. That means patient complains of feeling of something coming down, and it also complains discomfort on walking. also backache, dyspareunia, and difficulty while micturating or difficulty while passing urine and stool. So what is the management criteria for the prevention or the management of prolapse? First one being preventive measures, that is rest, care or daily care, proper nutrition, okay, and daily exercise for the predisposing patients. What is the conservative management being? Conservative cervical pessary implantation, but they give only some symptomatic relief, and pelvic muscle strengthening exercises which strengthen the pelvic musculature. Third being surgical, and which is a definitive treatment. Surgical methods: anterior wall prolapse, posterior wall prolapse, and pelvic floor repair and vault prolapse. And fourth is vault prolapse. So every type of prolapse has got a different type of surgical method. For anterior wall prolapse, what we do? Anterior colporrhaphy. For posterior prolapse, we do colpoperineorrhaphy. And pelvic floor repair, we do both anterior colporrhaphy as well as colpoperineorrhaphy. For vault prolapse, we do transvaginal or transabdominal approach. Okay. Anterior wall prolapse, anterior colporrhaphy is done for cystocele urethrocoele. So what is the main principle behind this? That is the attachment of bladder to the endopelvic fascia by cutting and removing the excess prolapsed part. So main principle behind this is attachment of the prolapsed part, that is bladder or endopelvic fascia, okay, to the endopelvic fascia. In the definitive treatment being vaginal hysterectomy, which is done only for a patient who has completed family and